Welcome, and thank you for joining me for Mastering the CMS Team Initiative, Transforming Surgical Care Payment Modules. This program is designed to guide hospitals, clinical leaders, and staff through one of the most significant changes in surgical reimbursement that we have seen in years. We are going to take this step by step, looking at what the module is, how it impacts hospitals, and what you can do now to prepare. At Relias, the mission is to measurably improve the lives of the most vulnerable members of society, as well as the people who care for them. This mission connects directly to this initiative because this module isn't just about reimbursement. It's about creating safer care, improving coordination, and reducing complications that affect vulnerable patients. It's a chance for hospitals to strengthen outcomes and compliance while improving the patient experience. My name is Aisha Kulor. I'm the Chief Clinical Officer with the Institute of Post-Acute Care. I bring with me more than 20 years of experience in nursing leadership, compliance, and post-acute care strategy. I have worked as a Chief Nursing Officer, Regional Director of Clinical Operations, Legal Nurse Consultant, leading organizations through CMS programs, survey readiness, and regulatory compliance challenges. What I bring to this session is both executive insight and frontline understanding, how to turn policy into practical systems that work. So this training is a roadmap. We'll cover the structure of the initiative, the impact on surgical care, how to prepare clinical teams, the role of technology, and finally, a readiness checklist. Each part will build on the last so that by the time we are done, you'll not only understand the requirements, but also know how to apply them in your hospital. Here's the agenda. First, we'll start with an overview of the model, what it is and why it's important. Secondly, we'll look at how surgical procedures are affected. Third, we'll dive into what clinical teams need to do to prepare. And fourth, we'll explore technology and training solutions to support your readiness. And finally, we'll wrap up with a readiness checklist to tie everything together. This sequence was made intentional to give you both the big picture as well as the practical steps. This initiative, the team's initiatives, as I mentioned, represents a fundamental shift in reimbursement. So instead of paying hospitals for each service like imaging, labs, or surgery itself, CMS is now evaluating the entire surgical episode. That begins at the time of admission and continues 30 days after discharge. Let's take a look at an example. If a patient comes to your hospital, is discharged after a colectomy, but returns within 3 weeks due to a preventable complication, the hospital is now going to be held accountable for that outcome. That's a major departure from the fee-for-service approach that we've all come to know over the years. So what is this team initiative? The team initiative is built around 4 core elements. The first is extended accountability. Hospitals are going to be accountable from the time a patient is admitted through 30 days after they are discharged. This means your responsibility doesn't stop once the patient leaves the hospital. I'll give another example here. If a knee replacement patient develops an infection at home within 30 days, CMS will hold the hospital accountable. This expands the focus from surgery alone to the entire episode of care. Second, this program builds on past programs. So team improves on earlier modules like the Hospital Readmission Reduction Program, HRRP, which targeted readmissions, but it was also very limited in scope. So team broadens the accountability to surgical care episodes, giving hospitals both greater responsibility but also a chance to improve their outcomes across wider patient populations. Third is the cost and quality evaluation. So this isn't just about outcomes, think about it. It's also about efficiency. Team monitors both the quality of care and the cost associated with delivering it. So imagine two hospitals performing colectomies. One has shorter average stays, fewer readmissions, and strong patient satisfaction, while the other struggles with prolonged stays and higher complication rates. Under team, CMS recognizes the first hospital as providing higher value care. And finally, performance-based incentives. Payments are going to be directly tied to performance. Hospitals that meet benchmarks will earn rewards, while those with gaps in care will face severe penalties. So, for example, a hospital that successfully reduces surgical site infections in spinal fusion patients through standardized wound protocols may earn incentives, while one with persistent infections risk payment reductions. So together, these four pillars, accountability, building on past programs, cost quality monitoring, and performance incentives, make up the foundation of the team initiative. So why does all of this matter? Because the impact goes well beyond reimbursement. Financially, hospitals will face penalties of up to 5% of Medicare payments if they underperform. But also, the opportunity for incentive is there if they excel. So from a delivery standpoint, the model pushes hospitals to break down silos and coordinate care across disciplines. Performance scores will also be made public, influencing reputation and patient choice. And finally, surveyors will be reviewing compliance more closely, so gaps in documentation can carry both financial as well as regulatory consequences. So, teams, again, is a major shift in your reimbursement. It ties the hospital payments to outcomes, not just services delivered. The financial impact, as I mentioned, is going to be huge because hospitals risk the penalties of up to 5% for poor outcomes, but those that are able to reduce complications and readmission can earn incentives. This module demands team-based, coordinated workflows, discharge planning, education for your staff as well as your residents or patients, and follow-up must begin at the time of admission. Because results will be publicly available, this means performance will directly shape the hospital's reputation as well as the patient's choice. Surveyors will be hyper-focused on thorough documentation of your discharge instructions, medication reconciliation, as well as patient education. A patient undergoing a colectomy who isn't given proper wound care education and is readmitted with an infection creates not only a financial penalty, but also a poor public score and regulatory scrutiny. That's the essence of team: financial, clinical, and reputational accountability all tied together. So let's take a closer look at the implementation timeline for the team initiative. I call 2025 the preparation year. This is the time to get ready. During this time, CMS encourages voluntary reporting. Hospitals should review affected surgical procedures, train staff, test documentation workflows. CMS will allow for voluntary reporting during this period, which gives hospitals the chance to practice without penalty. So think of 2025 as your dress rehearsal. For example, you might run a mock survey audit of all hip replacements to ensure documentation and discharge planning meet the team standard. Full implementation goes into effect on January 1, 2026. On this date, team officially goes live. All hospitals performing covered surgical procedures will be required to comply, and data reporting will become mandatory. From mid to late 2026, payment adjustments and public reporting will start. This is when CMS will begin applying performance adjustments and releasing public outcome reports. That means your hospital scores on readmissions, infection rates, patient satisfactions, and cost will be visible to your patients, families, as well as your competition. So the message is very, very clear. 2025 is your opportunity to prepare. 2026 is when compliance becomes mandatory. And by the end of 2026, your performance will become public. So hospitals that use the preparation year wisely will be in a much stronger position. Now remember, this initiative didn't come out of nowhere. It builds on the Hospital Readmission Reduction Program, or HRRP. HRRP focused on reducing readmissions for a handful of conditions, and penalties were capped at 3%. This new model expands that framework to surgical care and incorporates multiple quality measures and carries a much greater financial weight. So where HRRP tested the idea of value-based care, this program takes it system-wide. So in this first session, we introduced the CMS team initiative and its purpose: transforming surgical care, reimbursement through accountability, quality, and efficiency. We also discussed how team extends responsibility from admission through 30 days post-discharge, how it builds on past programs like HRRP, and how it represents a major shift in reimbursement. We also reviewed the key drivers: financial impact, care delivery, public reporting, and regulatory compliance. Team is broader, the stakes are high, and more influential than earlier programs. In Part 2, we'll examine the impact on surgical care and do a deep dive into how team directly affects surgical procedures and the new quality matrix hospital will be measured against. Stay tuned and join me.